Good morning. On this slide are the members of the meningococcal work group. We want to thank all of them for their participation. There's 3 meningococcal conjugate vaccines currently FDA licensed for infants and toddlers. There's the ACWYD or MenACWY, which was licensed in September 2010 as a 2-dose series starting at 9 months of age. The MenCY-TT, MenHibrix, which is a 4-dose bivalent meningococcal vaccine that's a 4-dose schedule starting at 2 months of age, licensed in June 2012. And the vaccine that we wish to discuss today is the MenACWY-CRM or MenVio vaccine that was licensed for infants starting at 2 months of age in August 2013. In terms of ACIP recommendations for infant meningococcal recommendations, in the October 2012 meeting, there was a recommendation for vaccination of high-risk infants. And the purpose of today's session is to consider adding MenACWY-CRM to the list of available meningococcal vaccines for use in high-risk infants. This vaccine provides protection against additional serogroups and may be used for infants traveling to areas where meningococcal disease is hyperendemic or endemic. This vaccine is given as 4.05 ml doses intramuscularly at 2, 4, 6, and 12 months of age, and it's immunogenic against serogroups A, C, W135, and Y, but it does not offer protection against serogroup B. And in general, you'll hear that the safety profile is similar to other childhood vaccines. In today's sessions, we'll have speakers go over the immunogenicity and safety of this vaccine. We'll present a grade evaluation, and there'll be a consideration for use of this vaccine in high-risk infants. We anticipate a vote and a VFC vote. Just to summarize other activities of the meningococcal work group, recently in March 2013, the comprehensive ACIP meningococcal vaccine statement was published. We reviewed and updated the Haemophilus influenzae B vaccination and there'll be a recommendation and report that was approved by this committee in February of 2013 and should be published in early 2004. And the committee is also working on an approach to candidate serogroup B meningococcal vaccines. Thank you.
Thank you, Dr. Rubin.
Okay. Thank you again for the opportunity to speak about MenVio. My name is Peter Dull. I'm the head for the meningitis and sepsis vaccines clinical franchise. So I lead the group that develops both meningococcal ACWY vaccines. We also have recently licensed a MenB vaccine in Europe and Australia. We're in development of an ABCWY vaccine, which is in clinical trials here in the U.S. and elsewhere. I also lead the group that leads the maternal immunization program for Group B strep vaccines as well at Novartis. So I'm going to keep it pretty narrow and talk about the incremental clinical data that has been generated for this vaccine since the last time I was here giving an overview of this vaccine, I guess a couple of years ago. I'm going to talk about 3 different studies. One, the study in a phase 3 study looking at the 2, 4, 6, 12-month schedule with concomitant use in routine infant vaccines. This is the study that is most prominently featured in the package insert that was part of the U.S. licensure label. I'm going to talk about a 2-dose toddler study or older infant study similar to the MenACWY dosing schedule, administered at 7 and 9 months of age and a 12-month schedule. Also have concomitant use data with MMRV in that study. And then finally, we have ongoing persistent studies. I'm going to give you the first look at a 40-month time point from the late follow-up after an infant series. So here's the description of MenVio or MenACWY-CRM. You can see at the top, it's indicated now for prevention of invasive disease caused by MenACWY serogroups. It's taken the last 5 or so years to change that, that 2 from 2 years in the lower limit to 2 months. But now it is indicated from 2 months of age to 55 years of age. The same slide is shown the last couple times I've been here. It's the same vaccine. It's 10 micrograms of the A component, 5 micrograms of the C, W, and Y component. The formulation is a liquid lyo formulation, so it's a liquid CWY, which is used to reconstitute a lyophilized A component. The vaccine contains no adjuvant and no preservative. So here's the scope of the clinical program that has provided the key data to support the licensure for MenVio in infants. The top 2 studies I presented on previously. The P5 study supported the dose and dose regimen finding conducted in the UK and Canada. Also showed data with good immunogenicity early in the series after the second dose at 5 months of age. The next is the P14 study. This is a study which was a phase 3 study conducted in the US and Latin America. Also had concomitant use in that case with Pediarix. So we both studied the Pediarix concomitant use as well as a pentosil-based concomitant use. That study I previously presented in 2011, and that showed concomitant use was supported for the antigens contained in Pediarix as well as Prevnar 7. Today I'm going to review the bottom 3 studies, the P23, a large 7,700 subject safety study conducted in the US, Latin America, and Asia. The _33 study, which provides the key immunogenicity data and a pentosil-based concomitant use analysis. And then finally the P21, which is the 2-dose older infant study. In total, in the clinical trial database that supported the licensure, approximately 9,000 infants have received the 4-dose infant series, and approximately 2,000 older infants received the 2-dose series. So here's the general design of those 2 infant studies I mentioned, the P23 and the _33. And this is a standard infant vaccination concomitant use study. So one arm would have received MenVio or MenACWY-CRM with routine infant vaccines. The other arm would have received routine only. One of the challenges to this program was the lack of a licensed but non-recommended comparator in the infant space. So as opposed to running a placebo-controlled trial after discussion with FDA, all of these studies in the infant indication were run with open label design. So an inherent challenge to what was available to us when we ran the clinical trials, but these were all open label studies. So study objectives to show the adequacy of the immune response after a 4-dose series, so a certain threshold needed to be met for ACWY after the completion of the series, and then concomitant use analysis with routine infant vaccines. Here's the immunogenicity data from the _33 study, very similar to the P14 study that I previously showed, so good responses after the initial primary series to the CWY. You can see 94 to 98% of these kids reached the protective threshold. After the booster dose at 12 months of age, 90+% across all 4 with 89% against serogroup A. You do see a decline prior to the booster dose, more markedly with the serogroup A, which we've seen in other studies using the human SBA, but good persistence in the others. Now moving on to concomitant use. So this again was a pentosil-based concomitant use study. We used ACT in this case it was the HBV vaccine was either the GSK or the Merck vaccine, but you can see across the top in the red bars are the titers elicited with the MenACWY plus CRM, and in the yellow bars you see the routine vaccines alone, and you see very flat across the top, very similar immune responses when given concomitantly with a pentacyl-based schedule. For the 4 components of the pertussis component, 2 different analyses were done, both a seroresponse and a GMC ratio. What I'm showing here is the seroresponse data. FDA has an inclination toward an interest in the seroresponse more so than the GMC ratio, so I'm bringing this data forward first. The GMC ratio data looked perfect. So actually the point estimates of the GMCs in the concomitant use data were actually higher when Menbio was given with pentacyl in this case. So all four of these pertussis antigens, non-inferiority was achieved on the GMC ratio. In contrast, here you see on the seroresponse for 2 of the 4, just below the 95% confidence interval, the -10 was missed for both pertussis toxin and FIM. On post hoc analyses looking at group and center effects, non-inferiority was in fact achieved for the pertussis toxin, and FIM remained outside of the non-inferiority limit. Moving on to the Prevnar 7, as both Menbio and Prevnar both contain the same CRM carrier protein. This is a topic of some interest. As I mentioned earlier, non-inferiority in the P14 study was achieved for 13 of the 14 serotype analyses in the 2 different studies. So P14 looked at post-3rd dose. 13 of 14 achieved the non-inferiority after the 3rd dose, and all achieved it after the 4th dose. So that was the P14 study. In this study, non-inferiority was achieved for 5 of the 7 after the 3rd dose. You can see for 6B and for 23F, non-inferiority was achieved. This same post hoc analysis was looked for center effect, and there was a strong center effect, and non-inferiority was achieved after analysis, looking with the center effect taken into account. More importantly, post-boost dose, we look at a different endpoint. So because titers are quite high after the 4th dose, using a threshold level is felt to be less interesting than using a GMC ratio. So the typical FDA expectation is that a GMC ratio analysis is used to analyze whether the titers are meaningfully impacted by the concomitant use of a new vaccine. And the lower limit of the 95% confidence interval is expected to be above 0.5 in that GMC ratio. And here you can see after the boost, the numbers have achieved the non-inferiority across each of the 7 serotypes of Prevnar 7. This is similar to what was shown in the P14 study. In the 2 different cohorts, 14 of 14 of those analyses were also achieved the non-inferiority. So you can see the number of analyses we're talking about. So there were 42 different analyses for Prevnar 7, post-primary and post-boost. And of those 42 different analyses, 3 non-inferiority were missed, of which after post hoc analysis, 1 of the 42 analyses were missed for non-inferiority. But importantly, after the boost dose, no non-inferiority analyses were missed in either of the studies that we analyzed. Moving on to reactogenicity, local reactions. Here you can see we look at injection site reactions, and in this case we looked at the injection site of either Menbio, or in the control group we used Prevnar as the comparator for injection site reactions. As you can see in the red bar, generally similar if not lower injection site reactions were solicited after Menbio administration. Not unexpected, it's an adjuvanted vaccine versus a non-adjuvanted vaccine, so no concerns seen in the local reactions. Similar analysis with systemic reactions. Here you see the same sort of analysis in the red. You see the systemic reactions solicited within 7 days of vaccination with either MenACWY-CRM with routines or routines alone. And you can see very similar rates both of any reactions or in the gray bar at the bottom or severe reactions. Very similar when MenVO is added incrementally on top of routine vaccines. Now just briefly onto the P21 study. So this is a late toddler vaccination or late infant vaccination. So first dose administered between 7 and 9 months of age, with a second dose administered at 12 months of age. The second dose was administered either alone or with the MMRV administered concomitantly at 12 months. The study was begun in 2007 and was conducted when MMRV was more routinely given at the 12-month dose. And so the study objectives were, again, sufficiency of response after a 2-dose series. That same sort of threshold for ACWY needed to be met, and then non-interference with the concomitant antigens. Here you can see the responses to the first dose in the orange. So after the 7 to 9 months of age dose, we took a blood at 8 to 10 months of age, and you can see lower responses for the A, W, and Y, but a good response to the C component after a single dose at 7 to 9 months of age. And then after the booster dose, again, very high responses, meeting the sufficiency criteria per the pre-specified sufficiency criteria from the study. Here you see the non-interference study analysis. So this is with the MMRV components, and the lower limit of the 95% confidence interval was required to be above -5%, and in each case, concomitant use was supported and non-inferiority was achieved for the MMR vaccine. Finally, now looking at the early look at the longer term, so from the earlier phase 3 study that I mentioned from P14, we are now following these kids out at 3.5 years of age, and we're going to get more data on them later this year. At 5 years of age, you can see in the red bar the primary response after the infant series, and then in the orange bar you do see declines, again most prominently with serogroup A, best with serogroup W and Y, and somewhere between for C. So this is at 40 months of age, between 34 and 76% for CWY, maintained persistence of bactericidal antibodies at the 1 to 8 level. So in summary, MenVO, MenACWY-CRM, well tolerated, immunogenic in infants, in over 7,500 infants studied with a 4-dose administration. No unexpected safety signals were observed. Similar immunogenicity was observed for all concomitant vaccine antigens, with non-inferiority achieved across each of the 7 serotypes after the 4th dose of Prevnar 7. I should mention we are have an ongoing study with Prevnar 13, which should have data in early 2014. MenVO is also well tolerated and immunogenic. It's a 2-dose series administered at 7 to 9 months of age with a second dose at 12 months, and we have, again, persistence data available at 40 months with ongoing studies with data at 60 months available, again, in early 2014. Thank you very much.
I think there's time for a couple of questions if people have regarding the vaccine presentation. Yeah, Dr. Warshawski.
Thank you very much for the presentation. Have you done any head-to-head trials with any other quadrivalent meningococcal vaccines? Is there any immunogenicity comparisons with others?
Yeah, I mean, during the licensure procedure, we, in the adolescent population, our licensure criteria were against MenACWY. So both in the 11 to 55 and the 2 to 10 age groups, the licensure was required. So non-inferiority was was achieved for those analyses. There were statistically higher immunogenicity against 3 of the 4 serogroups when studied versus MenACWY in the adolescent population.
Just a quick question on the co-administration with MMRV. Did you see any safety? I don't think you put any data up there in terms of the adverse effects. Was there much that came out with the toddler dosing?
Yeah, I mean, as far as we do have that data as well, and it's published, but there was no increase in the fever profile or change in the fever profile of MMRV, and it was really underpowered to have a conversation about febrile seizures.
Thank you. Dr. Dushan.
Thank you. Just a quick question on your P21 slide, the 7 to 9 month children. Do you have pre-vaccination levels, titers, for those time points?
Yeah, I mean, I guess you can also infer pre-vaccination from, this is the baseline infant data here from a U.S. population. So again, we see very low HSBA. I don't show the control group here, but it really stays quite flat. So at least in our HSBA in our hands, we see no background increase without vaccination. So those are all vaccine induced is the answer, yeah.
Okay, thank you very much. I guess we move on to Dr. Briere.
Good morning. I guess on the 3rd anniversary of GRADE, I will be presenting the 3rd grade evaluation for meningococcal vaccines, specifically for MenACWY-CRM. I will describe our study question and our GRADE assessment of the evidence for the benefits and harms outcomes. I will conclude with the working group's determination of overall evidence type for infant MenACWY-CRM and review the values and preferences and the estimated cost of the vaccine use. The first step in the GRADE process is to formulate the study question. In light of the current ACIP recommendation for meningococcal vaccine for increased risk infants, our study question is whether MenACWY-CRM should be used as a vaccine option for all 2, 4, 6, and 12-month-olds at increased risk for meningococcal disease. In GRADE, several key factors are evaluated when discussing considerations for vaccine use. First, the evidence is graded to determine the balance between benefits and harms and the overall evidence type. The values and preferences of all involved and the cost of the vaccine are also considered. Now we'll discuss the outcomes we graded and our determination of evidence type for these outcomes. After determining the study question, the work group selected outcomes that they felt were important to answer this question. The quality of the evidence for these outcomes was then evaluated. As you can see, this table shows the rankings of the outcomes considered for infant meningococcal vaccines. Only mild adverse events were ranked as not important. The final outcomes that were graded included short-term and long-term efficacy to assess the benefits of vaccination and serious adverse events, and interference to assess the harms of vaccination. In compiling evidence to grade for each of these outcomes, we used several inclusion criteria. We included U.S. and non-U.S. populations as long as the proposed U.S. schedule of 2, 4, 6, and 12 months was used for MenACWY-CRM. We compiled data for MenACWY-CRM by outcome and study design, randomized controlled trial, RCT, or observational study. There were a total of 4 studies that met our inclusion criteria. 1 was published, 2 were presented at a conference, and 1 was unpublished. Only healthy infants were included in these studies. All of these studies were RCTs, but 1 study did not have a control group for the full series short-term efficacy outcome, so it was observational for this outcome. Doug Campos-Alcott and I rated the evidence separately and compared results. Differences in results were discussed with the work group until consensus was reached. Due to the low incidence of meningococcal disease, pre-licensure clinical effectiveness studies are not feasible. Serum bactericidal antibody, or SBA titers, are used as immunologic correlative protection. Multiple studies have shown that human SBA titers of 1 to 4 correlate with protection against meningococcal disease. While these studies were based on SBA activity against serogroup C disease, human SBA titers greater than 1 to 8 are accepted as correlates of protection for vaccine licensure for other serogroups. Indirect data adds to our confidence in SBA titers as correlates of protection. Effectiveness was demonstrated to correlate with SBA titers in the adolescent MenACWY-D in the US and the MenC conjugate vaccines in the UK. As just presented by Dr. Dulles, short-term efficacy is achieved for all serogroups after the infant 3-dose series and the full 4-dose series. Duration of protection 28 months post 4th dose varies by serogroup. A higher percentage of patients had protective titers for serogroups W and Y than serogroups A and C post 4th dose. This waning immunity indicates the vaccine is unlikely to provide protection long-term, and a booster dose would be necessary for children at high risk long-term. In all studies that assess serious adverse events, events were recorded from the time of vaccination through 6 months post-vaccination and were physician verified. Among over 5,000 infants studied, at least one serious adverse event was reported during the infant series for 3% of study participants and 2% of controls. At least one serious adverse event was reported 1 month after the infant series by 1% of both study participants and controls. And at least one serious adverse event was reported 6 months after the full series by 2% of both participants and controls. 11 serious adverse events were considered possibly related to MenACWY-CRM by non-blinded investigators. They are listed here. 10 deaths occurred among subjects who received MenACWY-CRM. 2 deaths occurred among subjects in the control group. There was no clustering of any single one cause of death and no temporal clustering relative to receipt of vaccine. A 3-to-1 or 2-to-1 randomization was used in the studies, and in one study, the control arm crossed over and received MenACWY-CRM at 12 months. At different time points in the studies, there were between 7,000 and 9,000 total subjects that received MenACWY-CRM, and between 2,000 and 4,000 controls. Thus, the data were heavily weighted in person time exposure to MenACWY-CRM recipients. However, none of these deaths were considered related to receipt of MenACWY-CRM. Based on the 3 studies with data on interference with co-administered vaccines, antibody responses for diphtheria, tetanus, hepatitis B, and Hib antigens, and all poliovirus serotypes met criteria for non-inferiority after co-administration with MenACWY-CRM. In 2 of the 3 studies, non-inferiority criteria to some pertussis antigens were not met, as we just heard. In one study, non-inferiority criteria were not met for pertussis toxin or FIM. However, after adjusting for center differences, non-inferiority criteria were met for pertussis toxin. In the second study, non-inferiority criteria were met for protactin using GMC ratios, but not when using the secondary endpoint of seroresponse. In several studies, post-dose 3 pneumococcal IgG antibody responses after PCV7 co-administration did not meet criteria for non-inferiority for serotypes 6B and 23F. However, after adjusting for center differences, non-inferiority criteria were met for these serotypes. Post-dose 4, all pneumococcal serotypes met non-inferiority criteria in all studies. Looking at the benefits and harms for an infant MenACWY-CRM series, the vaccine is safe and immunogenic in the short term, although duration of protection 2 years post-vaccination varies by serogroup. In GRADE, all the available data for each outcome are evaluated on these 5 criteria, and a final evidence type is assigned. None of the studies for MenACWY-CRM were blinded. The work group felt that blinding was likely to introduce more bias for a more subjective outcome, such as serious adverse events, and less likely to introduce bias for an objective outcome, such as efficacy or interference. Therefore, we downgraded the evidence for the serious adverse outcomes if there was single or no blinding, but did not downgrade for efficacy outcomes. This evidence table lists the outcomes graded on the left column and the 5 criteria assessed on the top row. For risk of bias, we found serious limitations for the serious adverse events outcomes due to no blinding and large losses to follow-up or withdrawals. No serious limitations were found for inconsistency. Limitations were noted for indirectness for all outcomes because the data available were from healthy infants and no data on high-risk infants were available. The randomized control trial, the randomized control trial for long-term efficacy 28 months post-dose 4 was downgraded for imprecision because the sample size was less than 300 and the lower limit of the confidence interval showed only a small difference in HSVA titers compared to the control group. And there were no serious limitations for publication bias for any of the outcomes. So in summary, we downgraded the evidence for risk of bias for the serious adverse events outcome, for indirectness for all outcomes, and for imprecision for the long-term efficacy data. We did not downgrade the evidence for any of the other outcomes. Therefore, the overall evidence type is 3. Values and preferences of the public and providers were part of the body of evidence considered during the June 2011 and October 2012 ACIP discussions on infant and toddler meningococcal vaccination recommendations. In June 2011, the ACIP voted to recommend routine vaccination of increased risk toddlers 9 through 23 months of age, with the only meningococcal vaccine licensed for this age group at the time, MenACWY-CRM. In October 2012, after licensure of the first infant meningococcal vaccine, MenACWY-CRM, the ACIP voted to recommend vaccination of increased risk infants 2 to 23 months of age. With these 2 votes, vaccination with meningococcal vaccine became the standard of care for high-risk infants. MenACWY-CRM provides an additional vaccine option for these infants. A cost-effectiveness analysis was not performed for the use of meningococcal vaccines in high-risk infants. However, based on the low estimated number of infants per year that are at risk for meningococcal disease and the cost of the available vaccine options for this age group, vaccinating infants with MenACWY-CRM has a low overall cost. Therefore, in summary, the overall evidence type for the MenACWY-CRM data is a 3. The data support the safety and immunogenicity of the vaccine against serogroups A, C, W, and Y. As vaccination of increased risk infants is the current standard of care, MenACWY-CRM provides an additional vaccine option for these infants and has a low overall cost. The grade evidence tables for MenACWY-D and MenACWY vaccination in all infants were presented at past ACIP meetings and are currently posted on the ACIP grade website. The grade table presented today and evidence tables for the use of MenACWY-D and MenACWY in high-risk infants will also be added to the grade website. And I'd like to thank all who contributed to this evaluation, especially Doug Campos-Alcott and Farouk Ahmed. And I'm happy to take any questions if there are any now.
Any questions from the members here? Yes, Dr. Coyne-Beasley.
It looks like this will be addressed in the next presentation as I look at the slides, but I assume that we'll have some definition for the persons who will be using this vaccine about who we define as an infant of increased risk.
Exactly. Jessica will go over that in just a second.
I just have a quick question, and going back to the table, I'm a little bit troubled by the number of deaths in the slide 14 in the study group versus the control group, and just a little bit more explanation there would be helpful. I think we're starting out with healthy children, and just having that number of deaths in a relatively small cohort is pretty amazing to me. Cardiac arrests, cardiopulmonary failure, lung infections, and so on. These are things we're not used to seeing in healthy infants. So any explanation for that?
I don't think I can speak specifically to the causes of death, I don't know if Dr. Dull, if you'd want to add to that, or be able to address it.
I don't know, I guess I would just augment that a majority of the subjects were enrolled in the U.S., but a healthy, probably, I don't have the number off the top of my head, but probably 7 or 8 of those deaths out of the 10 were ex-U.S., were in Latin America or in Taiwan. So I think that also is an important consideration of infant mortality in that population. Yeah.
Was there similar recruitment between the two groups, however, for the control group and the active group?
Right, yeah, so the same randomization ratio was applied throughout. So, yeah, I think, again, I think the way we look at these when we try to tease out, is there something going on here, is, I think, Elizabeth alluded to it, is there a grouping of temporal association, that there's a mechanistic rationale as to why these things are happening? Is there a set of syndromes? Is it all respiratory deaths? Is it some autoimmune? And really, with looking at this, and FDA, of course, looking at this, we didn't see a concerning pattern and overall 3-to-1 randomization in person time years, 5-to-1 deaths. That sort of split is not unlikely, I guess, when you're looking at outcomes.
Thank you. Other questions or comments? Hearing none, let's then move on to Ms. MacNeil.
Good morning. Today I will be reviewing the proposed recommendations for use of MenACWY-CRM in infants at increased risk for meningococcal disease. On August 1st, 2013, FDA approved an expanded indication for MenACWY-CRM as a 4-dose primary series in infants with doses at 2, 4, 6, and 12 months of age. This vaccine had previously been approved for children and adults aged 2 through 55 years. MenACWY-CRM, or MenView, is a third meningococcal vaccine licensed for use in infants. MenACTRA is licensed as a 2-dose series at 9 and 12 months. Menhibrix, a bivalent serogroup C and Y meningococcal vaccine, is licensed as a 4-dose series at 2, 4, 6, and 12 to 15 months of age. MenACWY-CRM is the first quadrivalent meningococcal vaccine licensed for use in children 2 through 8 months. ACIP currently recommends vaccination of infants aged 2 through 23 months at increased risk for meningococcal disease. There is no recommendation for routine vaccination of all infants, although infants less than 1 year of age have higher rates of disease. This decision was based on the current epidemiology of meningococcal disease in infants, including the high proportion of serogroup B disease and the highest rates prior to 6 months of life. Meningococcal disease is currently at historic lows in the United States, therefore a routine infant recommendation would prevent a low proportion and absolute number of cases in this age group. Very few infants and young children are considered at increased risk for meningococcal disease. Infants at increased risk include those with recognized complement component deficiencies, functional or anatomic asplenia, including those with sickle cell disease, infants who are in a defined risk group for a community or institutional outbreak, or infants traveling to an area where meningococcal disease is hyperendemic or epidemic. The total number of infants at increased risk for meningococcal disease is likely somewhere between 2,000 and 5,000 per year out of a birth cohort of 4 million infants. The incidence of meningococcal disease continues to decline in the United States, and in 2012, 551 cases were reported among persons of all ages. 113 of those cases were reported among children less than 5 years of age. This table shows the average annual number of cases of meningococcal disease caused by each of the 4 major serogroups for children less than 5 years of age during 2010 to 2012. 50% of disease in this age group occurred in children 0 to 8 months of age, and overall 64% of disease in children less than 5 years was caused by serogroup B. As we saw in the earlier presentations, vaccination with 3 doses of MenACWY-CRM results in a protective immune response for all serogroups, although a lower response is seen for serogroup A. Following a full 4-dose series, over 89% of infants achieved protective antibody titers to all 4 serogroups. MenACWY-CRM is also immunogenic as a 2-dose series at 7 and 12 months of age. 2 years after a complete 4-dose series, antibody levels wane, especially for serogroups A and C, indicating the vaccine is unlikely to provide protection until the 11-year-old dose and may require a booster to maintain protection. When the 4-dose infant series was administered concomitantly with routine childhood vaccines, no interference was observed for diphtheria, tetanus, hepatitis B, polio, or Hib antigens. With a 2-dose series in older infants, no interference was observed with the MMRV antigens when MenACWY-CRM was administered concomitantly at 12 months of age. In several studies, seroresponse to the pneumococcal serotypes 6B and 23F was lower when PCV7 was co-administered with MenACWY-CRM. Post-dose 3 serotypes 6B and 23F did not meet statistical criteria for non-inferiority. However, no interference was seen for the other 5 PCV7 vaccine serotypes. Post-dose 4 non-inferiority criteria were met for all serotypes, including serotypes 6B and 23F. No data are available on the co-administration of MenACWY-CRM and PCV13. These interference data were shared with both the meningococcal and pneumococcal workgroups. The consensus was that MenACWY-CRM may be administered with PCV13, including in asplenic children, because the immune response was sufficient post-dose 4, whereas for MenACWY, interference was observed with the final dose at 12 months of age. MenACWY-CRM appears to be well tolerated and safe, with reported adverse events similar between infants receiving MenACWY-CRM with routine childhood vaccines and control infants receiving routine childhood vaccines alone. 11 serious adverse events were considered possibly related to the vaccine, which means vaccine receipt and the adverse event were reasonably related in time, but the adverse event could be explained by causes other than the vaccine. No deaths were attributed to the vaccine. With the licensure of MenACWY-CRM, infants at increased risk for meningococcal disease now have a 3rd vaccine option in addition to MenACWY and Menhibrix. Based on the immunogenicity, safety, and interference data for all 3 vaccines, there is no preference for any of the licensed vaccine formulations for use in infants at increased risk for meningococcal disease, except for 2 situations. First, Menhibrix does not provide protection against serogroups A and W, so it is not recommended for use in infants traveling to the meningitis belt or Hajj, where protection against serogroups A and W is required. Second, MenACWY is not recommended for infants 9 through 23 months of age with functional or anatomic asplenia in order to avoid potential interference with the 4th dose of PCV13. Guidance for use of MenACWY-CRM in infants at increased risk will be integrated with the existing guidance for Menhibrix and MenACWY. This table summarizes the 3 vaccine options for infants and toddlers at increased risk for meningococcal disease. MenACWY-CRM is the only quadrivalent vaccine licensed for use in infants 2 through 8 months of age. This table highlights the recommendations and indications for use of meningococcal vaccines in infants and children 2 through 23 months of age at increased risk for meningococcal disease. These recommendations are part of a larger table of recommendations which are included in the VFC resolution for children 18 years of age and younger. The portion of the VFC table that will be updated based on today's vote is highlighted here. In order to integrate the proposed recommendations into the current high-risk infant meningococcal recommendations, the following language will be included. Infants 2 through 23 months of age at increased risk for meningococcal disease should be vaccinated with an age and formulation-appropriate meningococcal conjugate vaccine. MenACWY-CRM is an additional option for vaccinating infants 2 through 23 months of age at increased risk for meningococcal disease. Language that will be included in the policy note as guidance for use includes those who remain at increased risk for meningococcal disease should receive a booster dose 3 years after the primary series and additional boosters every 5 years thereafter. If MenACWY-CRM is used to achieve protection against serogroups A and W meningococcal disease, a quadrivalent vaccine should be used to complete the series. The proposed recommendations to be voted on today are MenACWY-CRM can be used for protection against serogroups A, C, W, and Y in increased risk infants aged 2 through 23 months. Infants 2 through 8 months who travel to or reside in countries in which meningococcal disease is hyperendemic or epidemic are recommended to receive MenACWY-CRM prior to travel to provide protection against meningococcal serogroups A and W. Meningococcal or MenACWY-CRM may be co-administered with PCV13, including in asplenic children. Before I open this up to this presentation up for comments and questions, I wanted to thank the members of the meningococcal work group, and in particular, our chair, Larry Rubin. And I also wanted to thank Elizabeth Briere for keeping our work group activities moving forward in the last few weeks, and for her instrumental role in preparing our presentation for today's session. So I now welcome any comments or questions on the proposed recommendations.
Thank you very much. I see a number of hands going up. Dr. Curran.
So I wanted to focus on the recommendations for travel and specifically on the meningococcal A responses. And I was really wondering how this compares to the ACIP with respect to meninge A. And also, do we have any data? So we have data immediately after vaccination, and we have data at 40 months. Do we have data at intermediate times? Because my concern is obviously waning immunity to meninge A in travelers.
Right, and so for infants that are 2 to 8 months of age, this is the only vaccine that's available that has serogroup A in it. So for that group, this is the only vaccine that we would recommend, and that's what we're voting on today. I can let Peter talk about if there's any additional data. I don't think there is in between the 2 doses.
Yeah, I'm certainly no comparative data, but we have compared to MenACWY in older age populations and looked at later time points in 11 to 18 years, and we have comparable immunogenicity when looking at later time points for the MEN-A component, looking MenACWY versus MenVio. Is that your...
Well,
nothing for
I
infants.
guess what I'm wondering is, I understand in the 2 to 8 month age group, but I'm wondering in the 8 to 23 month age group, when, you know, in the older infant and toddler age group where there is an alternative, I'm just wondering about what the response and durability of antibody to meninge A is in ACYWD versus CRM. And do we have any data on that, or are there data that we know from ACYWD that could be informative?
We have not followed that older age cohort out. So
Yeah.
we can just, I guess, infer something from the data derived in older age populations as to how they might compare in a younger age population, I guess. Imperfect, but yeah.
Dr. Temte, may I say
Yes.
something? I just, in general, if you compare MenACWY and MenVio, the serogroup A responses do appear to be somewhat improved for MenACWY over MenVio. However, fortunately, with the use of menafravac in the meningitis belt, the risk for serogroup A disease among infants who travel is getting considerably smaller. And in fact, we've actually, the risk for serogroup A in travelers has never been as well established. There's never actually been a case of serogroup A meningococcal disease in a traveler to the meningitis belt. So while it's a recommendation, we felt like the immune response for infants in this 2 to 8 month range where there's no other options is sufficient, and the differences between MenACWY and MenVio in the older age groups aren't sufficient to prefer MenACWY over MenVio.
Thank you. Dr. Harriman.
Thanks. I just have a couple of comments for the working group and then one general comment. So, although it wasn't presented today, cost effectiveness data have been presented before. And to my knowledge, those evaluations did not include any indirect benefits of the vaccine in the sense of the herd immunity benefit due to decreased carriage, which of course other countries' data from the UK and elsewhere have shown dramatic impacts of herd immunity. So I would ask if the working group could do that kind of cost evaluation. That would be one comment. And the second comment is, as far as I can tell, there are 35 countries around the world outside of the meningitis belt that have a routine recommendation for meningococcal vaccines, and 28 of these countries have an infant or toddler dose schedule. Usually there are 1 to 3 doses total, and it's usually monovalent serogroup C vaccine. So now that we've got infant and toddler vaccines licensed in the United States, would the working group be willing to look at alternate schedules for meningococcal vaccines? For example, a very commonly used schedule in other countries is 1 dose at age 12 to 14 months and then a booster dose in mid-adolescence. And our neighbor in Canada could probably give us a lot of information about that. So that would be my second question for the group. And then my general comment is, if we're not going to have a routine recommendation for all healthy infants, I would just harken back to an editorial written 10 years ago by Paul Offit and Georges Peter in the New England Journal of Medicine, when at that time we had no routine recommendation for any meningococcal vaccines. And obviously there's a difference between public health policy and individual patient care. But in that editorial they stressed that if we weren't going to have routine use of these vaccines, policies and practices should be established to inform parents of infants and toddlers, at that time it was all ages, about the existence and potential benefits of the vaccine. And I would ask the working group and I guess others, are there plans to make sure that parents are aware of this vaccine? And that goes for providers too, because as we know, if something's not recommended by ACIP, they often think perhaps there's some reason they shouldn't be giving it, etc. So I'll stop there.
Amanda, do you want to comment?
Dr. Cohen.
Sure. So with regard to the herd immunity effects question, the herd immunity that was seen in the United Kingdom hasn't been seen with the quadrivalent vaccines in the United States. We haven't been able to show a reduction in carriage in the same way that they've shown a reduction in carriage with the MenACWY vaccines, and the immunogenicity was substantially greater. Now, the program that was introduced in the UK was very different than the program we introduced in the United States as well. So the actual impact on the programs are hard to compare. But even if you just look at carriage data alone, the work group did not feel like there was sufficient data for these vaccines to incorporate herd immunity into meningococcal vaccine effectiveness studies. We have looked at that in terms of sensitivity analyses, and it did not bring down the cost effectiveness substantially in the same way that it did in the UK with the program that they implemented.
Yeah, I guess I would still request that be looked at, because to me, when I think I've read all the papers now, and I think that there is some pretty strong evidence of a herd effect, and it does change the cost effectiveness evaluation.
Dr. Schuckett.
Yeah, I just want to make a comment for a number of the members who, joined the committee within the past 2 years, I think. Much of the run-up to evaluating meningococcal conjugate vaccines in ages under than 11 was based on the epidemiology of the disease in the U.S. rather than the vaccine performance, because many of the countries that have routine recommendations have much higher rates of C disease than we have. We've had this very surprising and interesting decline in endemic meningococcal disease in the U.S. in the paper that I think was handed out, so that there is much less disease to prevent or even to document a herd effect in or something. And then the other thing that the committee dealt with in the past few years was the surprising and somewhat disappointing waning of protection of the 11-year-old adolescent dose that led to a second dose in teenage years. So presumably ACIP does continue to look at the epidemiology and the performance of vaccines and so forth, but I think much of the decision making the past couple years that went into not having a routine infant or toddler dose schedule was the very low burden of disease, different from many other countries that have routine vaccination. On the other hand, of course, the U.S. has routine vaccination for diseases that other countries that have been using toddler doses of meninge for years haven't introduced yet. So, we've introduced some vaccines earlier and some not because of the epidemiology here.
Thank you. Other discussion? Dr. Briere.
Yeah, one of the things that I'm just wondering, we're recommending the vaccine in children who are at high risk for meningococcal disease, yet the studies are all done in healthy children. Are there going to be any studies for us to feel comfortable that we're getting similar immune responses in children who are immune compromised? Obviously, the children who are receiving it for travel, et cetera, we should assume that they'll have similar, but I would be concerned that as we found in other immune deficient populations who are older, we needed to have additional doses given in order to make sure that we had adequate antibody levels.
As far as I'm aware, there's no studies planned in children with these high-risk conditions, but they would be recommended to receive booster doses if they have complement deficiency or asplenia at 3 years after the primary series and then every 5 years thereafter, so in order to maintain protection.
But the question would be, would their primary series result in adequate levels to provide protection?
Yeah.
Dr. Grog.
Yes, Stan Grog with American Osteopathic Association. In the second bullet point, I just have a question. In the last sentence, it says, prior to travel to provide protection against meningococcal serogroups A and W. Why not just end it at the end of to travel rather than adding, because it makes it look like it doesn't protect against the other two at all.
I think we can make that change. We were trying to highlight the fact that A and W are the real risk travelers, but that's certainly, we can change that.
Dr. Pickering.
Yeah, I have a follow-up to Ruth's question, and it deals with slides 14 and 16 that Peter Dahl presented. If the assumptions are that 1 to 8 is a correlate of protection, secondly, that serogroup A, I think Amanda told me there's been one case in the last 10 years in the United States, is rare. But travel, it still is a concern for mass gatherings. You look at the data here in making the recommendation that it could be used for travel in infants, but you look at the data and it shows that at the post 7 to 9 month dose, there's about a 50% protection that drops down to 25 or so. And as Ruth pointed out, the decay curves for the older groups, it's down to 10% out at 40 months. So it is the best, I guess, or one of the best, or the only vaccine that is licensed in this age group for travel. But shouldn't there be a qualifier that this is not a perfect vaccine? We're talking about levels less than 50% as a correlate of protection. So do you plan to put a qualifier in there to let physicians and parents know that?
I think that's a good point, and we can certainly discuss that more in the background section of the document. We do have recommendations in the infant statement from MenACWY that both doses be received prior to travel, and that they can be given as close to 8 weeks apart instead of making them wait until the 12 weeks, or in this case, it would be the second year of life to get that second dose. We do recommend giving 2 doses. We could also add some language about trying to receive the vaccine closest to that travel, which may protect infants during the period of travel. Infants who are living in the meningitis belt, for example, would be in a different situation because they would require longer-term protection. But for at least infants traveling, that may be of benefit.
Dr. Baker.
I don't disagree with Dr. Karen or Dr. Pickering. I just will point out that this is the only vaccine. It is imperfect. We don't counsel parents about other imperfect vaccines, and we certainly have them, flu being one. And with regard to Dr. Harriman's comment, that would be great in a perfect world, but the pediatrician or family practitioner has limited time to talk about routine vaccines, and educating parents about a very low prevalence incidence disease, I think, is not practical in terms of making sure uptake of routinely recommended vaccines happens.
Dr. Karen.
I guess just to follow up, I wonder if there could be in guidance language some indication that this is perhaps protective for the short term, but for an infant who is going to reside in the country, this may be inadequate protection against MenA.
I believe it's Dr. Faget.
Thank you very much, Dr. Walt Faget, National Medical Association. Again, I want to, at this point, ask that, well, there's a real concern about the use of the term routine vaccination for high-risk infants. I'm sure that was part of the confusion for some of the misrepresentation in the letter that was sent to the ACIP. In fact, our staff contractor did not really understand the implication of saying routine immunization. So I think this is something we need to look at. We're talking about immunizing high-risk infants, and to say routine immunization to the non-clinician, I think could be a question. So NMA fully supports immunizing high-risk infants and children. And again, as an organization, we fully subscribe to evidence-based approach. At this time, I do want to retract the letter that was sent. Is this the time, Dr. Pickering, to tell you that?
Yeah, I can just mention that a letter was sent to Dr. Pickering from the National Medical Association regarding the use of meningococcal vaccine in children. And so that will be, letter will be placed into the official minutes of this meeting. But if you want to continue from there.
Yes, we really urgently want to retract that letter. As a pediatrician and former NMA liaison to the ACIP back in the day, Larry, congratulations, by the way. But we really, our president, Dr. Lenore, and our chairman of the board, Dr. George Sanders, sent me here specifically to assure that the ACIP knows that we, the NMA, support our representative, who is Dr. Pat Williams. She brought it to our attention, the inaccuracies reflected in the letter. Indeed, we don't have disparities. I think Dr. Cohn's paper that you have before you fully shows decreased disparities. We in the NMA hope that we are part of the solution in that. So we really apologize for any misrepresentation that we're trying to put something conflictual in the record. But we do subscribe to an evidence-based approach in developing clinical guidelines. And so at this time, we want to emphasize that we support the recommendation as presented here now, that we're specifically supporting immunization of high-risk children, not as incorrectly stated in that letter, which we're asking to be retracted, that we're talking about routine immunization. Okay, I see that as a typo in people who didn't understand the difference. So again, we look forward in the NMA to really continue to work with CDC and closing the gap. It was so exciting to hear Dr. Frieden's comments, and we fully subscribe and will have all of our resources available to you to assist as we move forward. Thank you.
Thank you very much. And just the record will show the letter has been retracted. And the comment here goes into
right.
the
And
official
again, Dr. Pat Williams has the authority to really, from the very robust and elegant presentation here today, so we can add any comments to the record. Thank you.
Thank you very much. Other comments? Dr. Reingold.
Thanks. I have two questions, and they may reflect my being a new member. One goes back to Dr. Briere's presentation and in the grading of the evidence. I'm fully aware of the need to bridge from immunogenicity studies to make inferences about efficacy or effectiveness, but I wonder if it's wise in those tables to talk about efficacy when in fact all we really have is immunogenicity data. So I'm just curious in terms of the ACIP's general perspective on this, whether the language is better stating it as efficacy when in fact all we really know is bridging from immunogenicity data. The other question I have relates to the whole question of recommendations for travelers and what we know about the dynamics of the immune response following immunization and how quickly the antibody levels rise. My concern is, as a frequent traveler, many people rush to get their shots right before they leave. And while I take the point that we don't want people getting vaccinated too far in advance, I'm not sure we want them getting vaccinated right before they leave either. So I'm wondering just how precise the recommendations are for travelers regarding the timing of these doses.
So we actually don't give any recommendations with regard to timing for doses. I think there may be language saying 2 weeks prior to travel, at least in the older age groups. The only recommendation we have specifically is that the 2 doses may be given at a shorter period of time to get that second dose in prior to travel in this infant toddler age group.
I'd just add, I think there are requirements for the Hajj for getting a visa to document your vaccination, and then for Africa it's much looser. But as was said before, we have no real documented cases in travelers to Africa.
Dr. Kempe.
Actually, it's Kemp, so that will make it so much easier, because you don't now have to say Temp-T.
I have been wrong all these years.
I have to take the E off my name, I guess. I have a question about potential confusion about the issue of MenACWY co-administration with PCV13, and whether there needs to be a clarification about whether it's okay then to cross over and use MenVio in that instance. Or, you know, I'm feeling like that's going to be a point of confusion. Wonder if that should be clarified.
So when these recommendations will be integrated with the recommendations for MenACWY and MenACWY, and we will make it clear that MenACWY in children with asplenia, MenACWY is not recommended until after age 2 years of age, but MenVio may be used in children with asplenia up through age 2 years and beyond. After age 2 years, the recommendations for MenACWY are that they be spaced, that you get MenACWY 1 month after your last PCV13 dose, in case you haven't received your final dose prior to age 2 years. So we hope when we integrate the language, and you'll receive the notice to readers prior to publication, that, and you guys will have an opportunity to comment on that, that it will be clear.
Oh. Dr. Lair?
Just a reminder that this is a very rare situation, probably less than 1 in 1,000 kids. So as a practicing family physician, I'm going to have to look this up every single time and read the book. This isn't something I'm going to have in my memory at all.
Any additional comments? I think there are some public comments out there. And if I may call on John Becker. And we'd like you to state your affiliation and any conflicts of interest.
Good morning. Oh, is this? Okay. Good morning. I'm an independent LGBT activist and an advocate for our community, and I'm here on my own with just as a concerned citizen. I represent gay, lesbian, bisexual, and transgender Americans who are concerned about the growing threat of bacterial meningitis in our community. There has been an outbreak of meningitis in the gay communities of several major American cities in recent years, with 7 deaths in New York City alone and other deaths reported in California and Utah. We believe the best way to ensure that bacterial meningitis does not kill any more innocent people is to expand the vaccination program in the United States as widely as possible. We are asking ACIP to expand its recommendation of the bacterial meningitis vaccine to include children and infants as young as 6 months old. Expanding the vaccine would help protect the hundreds of thousands of same-sex couples in the United States with children. Current Census Bureau estimates are that there are at least 115,000 same-sex couples in this country that are raising children. And expanding the vaccine recommendations would also increase herd immunity to protect people with compromised immune systems. And in our community, that's especially important because of the heightened incidence of suffering, people infected with HIV and AIDS. I've recently launched a campaign calling on the CDC and ACIP to help protect the lives of LGBT Americans by expanding the vaccine recommendations for bacterial meningitis. So far, this campaign has received more than 14,000 signatures, and we've just begun. We should probably meet the 15,000 threshold today. We will continue to push for the vaccine program to be expanded because we believe strongly that it offers the best chance to ensure that this deadly disease never again threatens our community. And we in the gay community unfortunately know too well how quickly an outbreak can turn into an epidemic. So we are incredibly fortunate to have a safe and effective vaccine available, and it's essential, in my view, that we expand its use far and wide to prevent this disease from spreading. Thank you very much.
Thank you very much. And let the record show also that the letter or the petition has been distributed to ACIP members and will be placed into the minutes of this meeting. Also, I just for the record, I'm just going to mention that Dr. Faget from National Medical Association is the speaker of the House of Delegates of the National Medical Association, just so we have that. Is that correct?
Yes, it is. I'm also assistant professor of community and family medicine, Howard University College of Medicine. Thank you.
Thank you so much. And do we have Chris Boone?
Hi, I'm Chris Boone. I'm here with Meningitis Angels. I have no conflict. This is my wife, Heather, and my son, Ethan. I'm not a public speaker. I'm probably going to get emotional. I'm sorry. On June 15th, 2008, my healthy 7-month-old little boy started running a fever. 30 hours from running that fever, his heart stopped. He had meningococcal. 13 days later, they amputated all 4 extremities. Sometime after that, his nose fell off his face. After 65 days of being in the hospital and 5 operations, they were on. His little body was destroyed. He's had surgery every summer to reconstruct his face. And I think it would be irresponsible not to vaccinate children from meningococcal disease. Thank you.
And thank you, Mr. Boone, for willingness to share that personal story. We have Frankie Miley.
Hi, I'm Frankie Millie. I'm the National Director of Meningitis Angels, and I am the mother of an only child who died from meningococcal disease at the age of 18, totally healthy. And I just wanted you to meet Jeremiah Mitchell, who's 10 years old now. Jeremiah's first grade class in Uliga, Oklahoma, had an outbreak. 6 children in that class within 48 hours contracted meningococcal disease. 2 of them died. And you see Jeremiah. Jeremiah has had massive face construction. The damage to his body is massive, but I'm proud to tell you he has a 12th grade reading and language skill. So, you know, I went to all the ACIP meetings a couple of summers ago, and time after time I heard it's not cost effective. It's the incident rate, it's not high enough. But yet, every parent who was there, who was against vaccines, voted when the vote came down to vaccinate infants against this disease, even those parents who were against it. You know, we educate parents in this country who are anti-vaccine. We spend a lot of money and a lot of time doing that. But we're not educating parents on a disease that can do this to a baby or kill my son in 14 hours, my perfectly healthy son who didn't even have a cavity in his mouth, but had blood coming from every orifice of his body in 14 hours. We worry about cost effectiveness. Is this cost effective? Is Ethan cost effective? The hundreds of children within our network are all not at high risk. I say to you, one baby, one child, one teen is too many, especially when it comes back to being yours. You know, I'm standing here today and I'm going to tell you, I have the utmost respect and admiration and gratitude to these people right here because they dedicate their lives to this, to making sure our kids are vaccinated. And I'm really disappointed, though, that we're only looking at this for high risk. What is high risk? You look at statistics. I look at real little people, real little faces. I listen to parents every day of my life who watch their kids have seizures so bad they have to have parts of their brain dissected. Who every time they take them to the doctor, they get revisions on amputations. Who develop kidney disease, who develop joint disease, who have, once they reach puberty, they develop emotional problems and anger issues. We've seen suicide within our families, high divorce rates. My God, please. This should be a routine, at least permissive recommendation for all of our infants. Give us all that chance. Let our parents be educated. Let our healthcare providers be educated. Give us that. I'm real disappointed that this is only for high risk. I think they're all high risk, and they're all worth being protected. Thank you.
Thank you very much for your comment. Are there additional comments? Is there anyone who is willing to make a motion for the current proposal? Dr. Dushan.
I'd make a motion to accept the current proposal with the addition of language that would expand upon considerations for timing of vaccine for travelers who wish to be protected against meningitis serogroup A.
And would that be appropriate to be placed into the commentary section of the recommendation?
Yes, I think that could be an annotated part of the recommendation.
A second? Dr. Campos-Outcult. Further discussion? Seeing none, why don't we start with voting, and we'll take Dr. Vasquez and go counterclockwise from Dr. Vasquez.
Vasquez, yes.
Coyne Beasley, yes, but I would like for us to look in the future about making this a permissive recommendation if the data support that.
Rubin, yes.
Jenkins, yes.
Harriman, no.
Bocchini, yes.
Reingold, yes.
Duchin, yes.
Kemp, yes.
Karen, yes.
Temte, yes.
Anna, yes.
Pellegrini, abstain.
Campos-Outcult, yes.
Harrison, yes.
The motion is passed, and I believe we are at a break time. Oh, no, we have a VFC resolution. Sorry about that. So, Dr. Santoli.
Hi there. The purpose of the resolution, the vote for today, is to update the resolution to include use of a meningococcal vaccine recently licensed in a new age group and to simplify the language within the recommended vaccination schedule and intervals section. The eligible groups for the vaccine remain unchanged. You see a slide that will be familiar to you from the last presentation for the high-risk children 2 months to 10 years of age, and this summarizes which vaccines are recommended for which groups. The second is the recommendations for the 11 to 18-year-olds, which we didn't talk about today. This is from the prior resolution, although it's been rearranged and streamlined to be more succinctly presented, but there aren't substantive changes. And then the table notes, and I can go back, I'm going through it quickly, but I can go back. The table notes, the first 3 footnotes, just talk about the different groups of high risk and how those groups are defined. And then for the recommended dosage and the contraindications and precautions, there are no changes. And then, as always, there's a statement about when recommendations come out that there could be a URL that would be referenced rather than necessarily needing to make changes to this document. And that's the resolution.
Discussion. I see Dr. Lair.
Could you go back about 4 slides? I thought I saw HIV on the high-risk group. 2 more. So that's, I think, different than some of the other high risk defined in some of the previous presentations.
And so I'll take you to where that comes into play here under the adolescents with complement component deficiency or functional or anatomic asplenia HIV infection if another indication for vaccination exists. So that language wasn't in the front, but it was here in terms of how to use the vaccine.
Jeannie, I think
Yes.
that in the actual language in the written resolution, HIV infection is not included. I think a couple of years ago that was clarified, and I believe if I reviewed the actual language, it's not included in this eligible group. But the recommendation is if a child with HIV does have another indication that they should receive 2 doses.
So if folks would like to vote to remove it from the eligible children section, you're saying it's not in the resolution that we have on the web? I'll check. I thought it was, but we can certainly remove it if that's the request from this section of the resolution, and then keep it listed as it is in the table. I'm happy to make that change if folks would like that, so that wouldn't be confusing in the eligible group section, just to delete the line.
I think we're checking the language. I think if somebody could check the language that's actually published. I thought we did make this change 2 years ago.
But I could make it now, whether we made it 2 years ago. I'm happy to take it out, but just still to keep it, I'm assuming you mean still to keep it in the table as if another indication exists?
Yes.
Other questions or comments?
Dr. Rubin.
I mean, just to clarify that I think that it should be deleted from this slide, because I don't think we want to indicate that all HIV-infected children should receive meningococcal conjugate vaccine unless they have another high-risk condition. And I think it's fine to keep it later, because if they do get it, they should get a 2-dose regimen.
Any other discussion? Yes, Dr. Grog.
Yeah, Stan Grog. I just have a comment, and I hate to even bring it up, but it looks to me like travelers in this case would be covered by VFC. Typically, travel immunizations are not, but asking clarification here.
So, yes, that's what's included in the current recommendation and was
I'm glad
not
to see
proposed
it.
to
I'm
change.
just surprised that it is.
Any other discussion? Seeing none, anyone willing to call, or I'll call for the question? Dr. Bennett? Okay. Do we have a second? Dr. Bocchini? Further discussion? Okay, and we'll start with Dr. Kemp and go clockwise.
Kemp, yes.
Karen, yes.
Tempty, yes.
Bennett, yes.
Pellegrini abstain again.
Campus Outcall, yes.
Harrison, yes.
Vasquez, yes.
Coin-Beasley, yes.
Rubin, yes.
Jenkins, yes, and I think you ought to give up the clockwise and counterclockwise and just say right and left. You're confusing everybody.
Point taken.
Harriman, yes.
Bocchini, yes.
Reingold, yes.
Duchin, yes.
And the resolution passes. We will take a, looks like about a 25 to 30 minute break, reconvening at 10:45.